the message starts to be that screening doesn't work very well, that screening creates anxiety without reducing death. As Vinay Prasad pointed out, per protocol analysis is what you do when you're too dumb to understand intention to treat. All these people, like Dr. Baig, who are coming out in these different journals claiming that we know colonoscopy saves lives, are liars. We don't know that. Even NPR gets this wrong. Colonoscopies save lives. Period. Full stop. Definitive statement. Based on nothing. Based on absolutely no science. Very understandable for a layperson to say that. For a GI specialist to say something like that is either indicative of a complete lack of understanding of science or a deliberate attempt to defend a lucrative procedure. So we are back with Failures of Cancer Screening, Part 2, the NordICC trial. This was released October 2022, so very, very recent, and for me, really changed the core understanding I have of many, many aspects related to cancer screening. If you had asked me before the publication of this trial, I would have said that colon cancer screening with colonoscopy was the gold standard of cancer screening, that it saved lives, that it was a simple, important test to get done for anyone who qualified. I was a believer, in other words. And this study has really upended that for me. More than the study itself, the response in the physician community, in the publication community, especially from GI doctors, has been extremely disappointing. And we'll go into a lot of the controversy that's been stirred up by this trial and the conflicts of interest that I perceive. Before I get into it, I want to make sure that we all are on the same page. What is a colonoscopy and what is involved? The point of a colonoscopy is to try to detect tiny colon cancer before it becomes a big problem. It's a screening test. So the patient has to drink a gallon of a laxative called Go Lightly, and it makes you literally shit your brains out. I mean, you are on the toilet basically for 24 hours. It is a very, very harsh laxative. It is an extremely unpleasant experience. Many, many patients have told me that the preparation for the procedure was far worse than the procedure itself because of the amount of harsh, forceful diarrhea that is caused by this medication. And that is necessary to completely clean out the colon of any bit of poop so that the walls of the colon can be seen by the camera. So after you clean out all the poop from the colon with this harsh laxative, you go in the day of the procedure. The doctor takes a long camera and goes up your anus, all the way up around the colon, up the left side of your colon, across your belly, and down the right side of your colon, all the way to what's called the cecum, which is where the small intestine and the large intestine meet. And then the camera is pulled back out while the GI doctor, the physician, watches the walls of the colon through the GI scope, and I'll post a picture right here, watches the walls of the colon for any sign of abnormality. And if the doctor sees an abnormality that could be a tiny bit of cancer starting to form, then that bit is cut off and sent to the pathologist who looks at it under a microscope and says whether there was cancer there or not. And if there was precancer there, then they recommend you get your colonoscopy more frequently. If it was not, or if there was no polyps seen at all, then you repeat the whole process in 10 years. That's the intent. The idea is that colon cancer is slow growing. If you catch it early, you should be able to stave off a problem down the road. You should be able to avoid late-stage colon cancer where it's metastasized all of your body. It can be very painful. And that's the intention of the screening program. However, despite the fact that this has become a strongly recommended screening methodology in the US, there have been no actual randomized controlled trials on whether it works to reduce death. So, this trial was undertaken in Europe in a multinational group involving Poland, Norway, Sweden, and the Netherlands to test whether a screening program recommending colonoscopy would effectively lower the risk of death or the risk of death from colon cancer. So, that's the background of this study. Cutting to the chase, the study did not show any benefit, did not show any reduction in mortality, did not show any reduction in mortality from colon cancer, it did not show any benefit to inviting someone to get a colonoscopy. There have been a large number of responses to this because it has become such a grained-in part of medical training, recommendations, national recommendations, and frankly, a huge source of income for the people performing the colonoscopies. So, I want to go through the trial. I want to go through the controversies, the objections, the criticisms of the trial, and discuss why those criticisms are fundamentally based on a complete lack of understanding of science, and why this trial, having been done very, very well, is the first and most important bit of information we have on the effect of colonoscopy. And there are upcoming trials that will provide more information, but this trial so far is the only really strong bit of information we have, and that bit of information says that having a colon cancer screening program with colonoscopy is not effective in reducing death or reducing death from colon cancer. Now, I've been very careful in my words thus far, and the reason is that this trial was a pragmatic trial, meaning they were testing whether inviting people to get a colonoscopy as a part of a screening program was effective in reducing colon cancer death. It was not testing whether doing a colonoscopy reduced colon cancer death or death overall. That would be a different trial. It would have to be designed entirely differently. So, coming back to the trial right here, although colonoscopy is widely used as a screening test, its effect on the risks of colorectal cancer and related death is unclear. That's the premise of the study. And the reason it's unclear is there has never before been done a randomized controlled trial of colonoscopy. All the recommendations that exist have been done on lesser bits of evidence. The gold standard of evidence in medical science is the randomized controlled trial. So, we performed a pragmatic randomized trial involving healthy men and women aged 55 to 64 years of age. Basically, they randomized people so that out of 84,000 people, 1/3 of them got an invitation to get a colonoscopy. They got a recommendation to come have a colonoscopy for screening. The other 2/3 did not. Out of those 2/3, and in fact everyone in the study, if anyone developed symptoms of any kind, they were bleeding, change in stool caliber, weight loss, abdominal pain, any problem that would ordinarily have them get a colonoscopy, they got a colonoscopy. So that group is the control group, and the control was usual care. And what that means is that if they had symptoms, they were treated appropriately. And that is how they found colon cancer in those groups, is because people develop symptoms. Importantly, in the usual care group, almost no one got a screening colonoscopy, meaning no one in the control group subverted that by going out and getting a colonoscopy when they didn't have any symptoms. So, what happened? Well, after the randomization process, they randomly selected 1/3 of people to be in the intervention group and 2/3 were in the control group. In the intervention group, only 42% of people ended up actually getting a colonoscopy. So all of them were invited in the intervention third, but only 42% of them actually got a colonoscopy. And you'll see that come up as one of the major criticisms of the trial, but I'm going to go through why that's not really a fair criticism. But out of all the people who were invited to get the colonoscopy, 42% got it, and all of the 84,000 people were followed for 10 years to see how many of them developed colon cancer, how many of them died from colon cancer, and how many of them died overall for any reason. And then the two groups were compared to see whether inviting someone for a recommended screening for colon cancer reduced their risk of death, death from colon cancer, or colon cancer overall. And as I said, there was no change in the risk of death. There was no change in the risk of death from colon cancer. There was a slight decrease in the number of colon cancers that happened. The number of non-fatal colon cancers were reduced slightly in the group that was invited for screening. So, median follow-up of 10 years. Cases were detected in the invited group and 622 cases in the usual care group. Remember, the usual care group is twice as big. About twice as many cases were detected because the group was twice as big. In an intention to screen analysis, the risk of colorectal cancer at 10 years was 0.98% in the invited group and 1.2% in the usual care group. A risk reduction of 18%. Now, you might be appropriately wondering how you could subtract 0.98 from 1.2 and get 18%. This is what is called a relative risk reduction. This trial was actually very well done. They actually include number needed to treat. They include absolute risk reduction. They include the actual statistics. So I suspect that this publication was actually not trying to pull the wool over anyone's eyes. I don't think these guys are bullshitting. I think it's an incredibly well done trial. But it does serve to highlight why relative risk reduction is such a tool for those who would obfuscate the importance of things. And we will see that in the criticisms from GI doctors, that they absolutely hinge upon the relative risk reduction. So we're going to talk about how relative risk reduction is calculated and why it is such a nonsense number. That said, that is the risk of colorectal cancer. That's the risk of having a case of colorectal cancer. The risk of death from colorectal cancer was 0.28 in the invited group and 0.31 in the usual care group, and there was not statistical significance detected. So the risk of death from any cause was 11.03% in the invited group and 11.04% in the usual care group. Obviously, not statistically significant, essentially no difference in the risk of death overall. I have a tremendous objection to the conclusion that is written here. If the authors actually wrote this, they should really be ashamed of how they have concluded this. And watching interviews with them, I really am forced to wonder whether this was a tagline generated by the New England Journal instead of generated by the authors. Because while this is marginally true, there was a very tiny reduction from 1.2% to 0.98%. That is hardly the takeaway from this study. The fact that there was no reduction in death from colon cancer, there was no reduction in death overall, is the takeaway from the study. That's what the study was designed to test, that's what the study tested, and that's what the study showed. But let's get into some of the science and some of the terminology around this trial and some of the critiques that are incorrectly leveled at this trial. The first is this number, risk reduction. This is a relative risk reduction. I find it an extremely misleading figure, as I've said before, and here's why. Relative risk reduction without absolute risk reduction is a nonsense figure. Absolute risk reduction is the difference between the intervention group and the non-intervention group. That's subtracting 0.98% from 1.2%, and that's the absolute risk reduction, 0.22%. As you can see here, if in a hypothetical trial you had 100 people, 50 were treated, 50 were given placebo, 10 out of the 50 people who were treated ended up dying, and 20 out of the 50 people who were given placebo died, then the absolute risk reduction is 40 minus 20, 20%. One of the ways we represent that as the number needed to treat. That's, you would need to treat 5 people in this hypothetical trial to prevent 1 death. Risk reduction, on the other hand, is comparing the reduction from the placebo amount. So, once again, same scenario, same numbers, 50 treated, 50 placebo, 10 out of the 50 treated died, 20 out of the 50 placebo died, that's 20 and 40%. And the relative risk reduction is not just the subtraction, it's this formula here, is 40 minus 20 divided by 40. That's the percent reduction from 40%, or the reduction expressed as a percent of 40%. So that is a 50% reduction. And you can see that 20% is 50% of 40%. But it's a bigger number, and that's why people like to publish it. But when things are rare instead of 20% and 40%, this really starts to get out of hand. And I've unfortunately done a little switcheroo here on you. In this case, 2 out of the 50 who were treated died. That's 4%, and that's represented in blue this time instead of red. I ended up switching the colors by accident. Here, 3 out of the 50 with the placebo died, and that's 6%. And so the absolute risk reduction is 2%. That is, 6% of the people with placebo died, 4% of the people who got treated died, and that's a 2% reduction. But the relative risk reduction, of course, is 33%, because 4 is 33% less than 6. And of course, if I say that there's a 33% reduction, that sounds great. A 2% reduction doesn't sound that great. And that's why people love to publish the relative risk reduction, because it makes unimportant things sound important. So what was the absolute risk reduction in death? 0.01%. It was not statistically significant. The study was not strong enough for that to be a meaningful amount. What was the reduction in risk of colon cancer death? Again, did not reach statistical significance. What was the reduction in risk of getting colon cancer in 10 years? It was 0.22%. And that's non-fatal colon cancers. Now, what that means, as these authors point out, is that you would need to invite 455 people to get a colon cancer screening in order to avoid 1 non-fatal case of colon cancer in 10 years. And no matter how many people you invite, an infinite number as far as this study can tell, you will not reduce colon cancer deaths, nor will you reduce death overall. Now, I want to get into some of the critiques of this study and explain why those critiques are disingenuous at best and self-serving at worst. Here is the first example I will show you of this critique, that among the individuals randomly assigned to the invited group, only 42% actually got colonoscopies. And thus, we should not conclude that colonoscopy is useless. We should still do colonoscopies according to this author. And this one is the most egregious article I've come across, and I'm going to tear it to shreds here. As GI physicians, we know that colonoscopy saves lives. How do you know that? Dr. Nadim Baig of the New Jersey Allied Digestive Health. How do you know that? There has never been a trial, a randomized controlled trial of colonoscopy. This is the first one. So how exactly do you know that? You cannot know that. You are biased by the fact that you are paid to do colonoscopies. That's the only conclusion I can come to. Other doctors have been more straightforward and more honest than this one, but this is an absolute travesty of commentary. Once again, it reduced the risk of colorectal cancer by 31% and cut the risk of dying from colorectal cancer by 50%. We're going to get into how those numbers were created, but you should already know that they are relative risk reductions. As I said, the favorite tool of bullshit artists, which Dr. Baig clearly is. There is another complaint here that the average adenoma detection rate is 39% in the United States and was below 25% for almost a third of the endoscopists in the trial. Basically, he is implying here that the study did not prevent cancer because the doctors in Europe doing these colonoscopies were not looking very hard or were not very good at colonoscopy and did not see the little polyps on the walls that they should have seen because they didn't see as many as is commonly reported in the United States. And I'm going to get to that critique at the very end. He also says that 1 in 4 of the colonoscopies was done with no sedation. This can increase discomfort, shorten the withdrawal time, and potentially lead to decreased polyp detection. That actually has not been shown anywhere. That's a completely made-up claim. And in fact, this study showed that, if anything, we should be doing fewer colonoscopies with sedation because there were zero perforations in all 11,000 colonoscopies, whereas in the US, we have a much higher perforation rate, partially because we always do them with sedation. But why is it unfair to claim that this 42% figure is irrelevant? It seems pretty logical. If you're a layperson, I think you can say, well, only 42% of the people got a colonoscopy, so why can't we just look at them? Look at the ones who got the colonoscopy and see if they had a lower risk of death. Wouldn't that be a better idea? Because I'm trying to decide if I should get my colonoscopy, and obviously you can't be helped by a colonoscopy you didn't get. So doesn't that falsely lower the results? Well, there's a deep problem with that. And the reason there's a deep problem with that gets into the core of how medical science is done, how statistics are calculated, and why we need randomization. Randomization is the word. A randomized controlled trial is the gold standard of medical testing, and there's a reason for that. Randomization allows us to compare apples to apples for groups. Let us suppose that I run a trial testing whether a particular medication saves lives compared to placebo. That's the control. First of all, you need a comparison to. And in a future video talking about the Orbiter trial, I will point out why the lack of a control group can lead us astray as well. But in this case, we're going to talk about how randomization allows us to do direct comparisons. Suppose I ran a trial comparing a drug with placebo, and I was trying to see if this drug reduced death. And I ran this trial, and I published a great article saying that this drug reduces death. And then come to find out that I only gave the drug to athletes, and I gave the placebo to non-athletes. Well, now you have questions, I imagine. Was it the drug that saved lives, or was it the fact that they were athletic? What if it's more subtle than that? What if I didn't give it only to athletes, but I advertised the drug at athletic events? and I advertised the placebo at non-athletic events. What if it wasn't that obvious? What if I didn't even know, but unbeknownst to me, I was advertising this study at coffee shops, and the coffee shops whose patrons ended up getting the drug were non-smoking coffee shops, and the placebo group was smokers' coffee shops? Or what if there were more women at the drug coffee shops and the non-drug, the placebo coffee shops were more men? Or what if the people who got the drug tended to eat more salads or eat more meat or drink more coffee, or any number of the thousands of differences that can occur between groups of people? Maybe the people who got the drug were younger. Maybe the people who got the drug were richer. One of the ways we control for these factors is by randomizing who is in which group. By choosing at random, we hope we are able to control not only for the things we know make a difference, but for things that could make a difference that we're not familiar with. In this trial in particular, if you only look at people who got the colonoscopy, you are looking at a group of people who are fairly compliant. They got a single invitation to come get a colonoscopy to benefit their health, and they complied. They went through the whole pooping their brains out. They got the camera shoved up their butt all the way to their cecum, and they did that on the basis of a single invitation. That's a pretty compliant group. One is forced to imagine they are fairly health conscious and they paid attention to their health in other ways as well. It's hard to imagine that such a responsive group does not also eat better, is not also more active, is not also healthier in innumerable other ways overall. So it is not a fair comparison. In order to test whether colonoscopy itself reduced the risk of colon cancer or colon cancer-related death or death overall, not the invitation for colonoscopy, but colonoscopy itself, you could only do that fairly one way. You would take a group of people, invite them for colonoscopy. Of everyone who came for colonoscopy, that is, they've already done the prep and they actually show up to get a colonoscopy, you sedate all of them. One of them, you do a colonoscopy and you ignore the results. You don't do any polyp removal. You don't look for polyps. You just shove the camera in and pull the camera out. The second group, you do a colonoscopy properly. You put the camera all the way in, you look for polyps, you remove the ones you see, you test those for cancer, and then you follow both of those groups for 10 years. And when you follow both of those groups for 10 years, what you will find is if there is a difference, if there is a benefit to colonoscopy compared to sham colonoscopy. So in this example, the sham colonoscopy is your control. Then you will see whether colonoscopy itself, when done properly, actually reduces colon cancer death, or reduces death overall. That is the only way you could actually test that idea in a very exact way. We can get hints of that from other trials. And there are significant ethical issues with using that kind of a control. But on the other hand, as Orbita showed in The Lancet, and I'm going to do another video on that, assuming that we know what a control will show is a dangerous step. So, randomization is actually critically important. Now, can we see any evidence of the problems when we don't have randomization? And yes, we can. In this paper from 1983, it's a study of studies. They compared papers in which there was randomization to papers in which there was not randomization. And they found that in papers with randomization and blinding, 8.8% found a treatment effect. And in studies without randomization, 58% found a treatment effect. And that's exactly the same as doing this analysis by only looking at the 42% of people that got colonoscopies. You're going to inflate effects because you are pre-selecting, subtly pre-selecting a more health-conscious group of people overall. And what you are seeing is not the effect of the colonoscopy. You're seeing the effect of the unknown set of more health-conscious behaviors. And that is actually what is reducing the risk of colon cancer and the risk of death in that population. But all that aside, say, you know what, Dr. Hakeem, you're making a big deal out of this whole per protocol and non-protocol and randomization. That's all fine. But the real deal, you might say, wrongly, but you might say, is the people who got the colonoscopy. How did they do? Well, I'll tell you. The people who got the colonoscopy had a reduction in death compared to the people who did not get a colonoscopy. Now, we don't know if that's because of the colonoscopy or if that's because they are more health-conscious people. But there was a reduction in death. Well, that's great, you say. How much of a reduction in death? The reduction in death from colon cancer itself was 0.38%, and the reduction in death overall was 0.15%. And what that means is that if you ignore all the science and the fact that this was probably not because of colonoscopy, but because you are subtly pre-selecting a healthier group of people, ignore all that. If you decide to go through the prep, take 3 days off work, get a camera shoved up your butt, you will reduce your risk of death over 10 years by 0.15%. And if you do that to 667 people, you will prevent one death. So is that worth it to you for a 0.15% risk reduction? I would argue that you could pick a day, call in sick, and your reduction in risk from car accident would probably be comparable. Do that once a year for 10 years, and I suspect by taking an extra sick day, you'd have the same reduction in risk of death. Maybe 3 sick days, but at least you don't have to shit your brains out, right? Now, the other trial I want to talk about is an old trial. It's called ISIS-2. That was a critical trial in medicine. It was the trial that showed that using aspirin in people who were having a heart attack reduced their risk of death significantly. It became the standard of care. If you go to the ER with chest pain anywhere in the country, you will be given aspirin. And the reason you will be given aspirin was because of this trial, ISIS-2. When the study was published, the editors during peer review asked the researchers to subdivide the patients and detail which ones had benefited and which ones had not. The Oxford team regarded this request as bad science, but decided to comply, although in a very unorthodox way. They not only divided the patients, they divided them by astrological sign. And what they found is that those born under the astrological sign of Libra and Gemini did not benefit from aspirin, but those born as Capricorns benefited more. This was obviously tongue-in-cheek, because any scientific understanding we have of how heart attacks happen and how aspirin works indicates that it should not operate differently according to astrological sign. The reason the authors did this is to highlight the inanity and the incorrect concept of subgroup analysis. You cannot take a big study that is designed to study something and only look at a part of it and then try to make conclusions. Any study you see where they say, well, in the subgroup of diabetics, aspirin worked better, or in the subgroup of those with high blood pressure, or in the subgroup of men or women or whites or blacks or anyone else, you cannot make those conclusions in a trial that is not powered to make those conclusions. That is exactly true for the subgroup of people who got the colonoscopy. Trials are designed very precisely in order to answer scientific questions. If you want to answer a different scientific question, you have to do a different study. This study was designed to answer the question of whether a screening program for colonoscopy would reduce the risk of colon cancer-related deaths and reduce the risk of death overall in a population. And it did not. Trying to obfuscate that by only doing a subgroup analysis of the 42% that got the colonoscopy, what is called a per-protocol analysis to make it sound fancy, even though it's bullshit, just like relative risk reduction makes it sound fancy, even though it's bullshit, is an egregious attempt to bend a negative study into a study that gives the outcome that you want, because you know that colonoscopy saves lives. With all of that said, the most interesting part of this trial, to me, is that it is yet another example of how our concept of the importance of screening is falling apart in front of our eyes. Just as mammograms, just as PSA for prostate cancer, just as CT for lung cancer has fallen apart when we actually put it to the test scientifically, colon cancer screening seems to be falling apart. I myself would have been a significant advocate for colonoscopy before October of 2022. But this trial highlights to me that what I was taught in residency, what I have been reading in all of these summaries of guidelines and national guidelines, what I studied for the boards to pass my boards, was not based on science, was not based on evidence, but based on models and cohort analysis and case control, not actually testing our hypotheses. And when we got around to testing our hypotheses, the message starts to be that screening doesn't work very well, that screening creates anxiety without reducing death, that screening results in overdiagnosis, harms from overtreatment, without meaningfully reducing disease burden. As Vinay Prasad pointed out, per protocol analysis is what you do when you're too dumb to understand intention to treat, or in this case, intention to screen. And he's not wrong. All these people, like Dr. Baig, who are coming out in these different journals claiming that we know colonoscopy saves lives, are liars. We don't know that. We don't know that one way or another. And this trial indicates that a screening program of inviting people to colonoscopy does not save lives. We don't know whether colonoscopy itself saves lives because we would have to do a different trial to find that out. But we know that inviting people for colonoscopy does not. Even NPR gets this wrong. Colonoscopies save lives. Period. Full stop. Definitive statement based on nothing. Based on absolutely no science. Doctors push back against European study that casts doubt. Here's the bigger picture, NPR says. More than half the participants who invited never showed up for the procedure. A colonoscopy will only work if a patient gets one. Peterson says it's important to focus on the outcomes of the people who actually underwent the procedure, 42% of all participants. Among this group, people who actually got the colonoscopy, the risk was reduced by 31%. Relative risk reduction. The American Cancer Society says this result points to the value of continued screening, which is the exact opposite of what this study points to. This study points to the exact opposite of the idea that continued screening is valuable. So I want to go through a bit more detail about why per-protocol analysis is flawed and why an intention-to-treat analysis in statistics is an important standard to stick by. Imagine we are comparing a new surgery with standard medical care. And standard medical care may be pills, or it may be counseling, or it may be anything. But I've got a new surgery that supposedly treats condition X, except that I'm a fraud and I know I'm a fraud, and I'm doing a sham surgery. The sham surgery is this. I put the patient under anesthesia, cut open their belly, and sew them right back up without doing anything. So I know that the surgery is flawed, but the researchers don't. They're trying to tell whether my surgery really works. And what they do is they start with 100 patients in each group. They have 100 that get the surgery and 100 that don't get the surgery. And there's a 6-week waiting period to get the surgery done. Now, in both groups at 2-month follow-up, 30 patients out of 100 die. And the reason it's the same is because the surgery is a sham. It doesn't do anything. But 15 out of the patients in the surgery group died during the waiting period. So if we do an intention to treat analysis, you will reach the correct conclusion that there were 30 deaths in each group and the surgery doesn't work. If you do a per protocol analysis and you only analyze the patients that did get the surgery, that's 85 patients because 15 of them died, and 15 out of the 85 patients died, then you will think that 30% of the patients who got usual care died and only 17% of the patients who got the surgery died, and the surgery will look like it works. This mathematical error is why it is so important to stick to intention to treat. And the tagline that we're taught is once randomized, always analyzed. So in the Nordic trial, when they randomized people to be invited to colonoscopy or not be invited, all of those people have to be analyzed. You cannot only analyze the 42% of people who got the colonoscopy. It mathematically does not work and is bad science. Nearly 30% of the endoscopists who were included in the Nordic trial did not meet the adenoma detection rate. The adenoma detection rate is a measure of quality of colonoscopy because a certain percentage of colonoscopies should see an adenoma. The problem is that the rate of colon cancer and adenomas in Sweden, one of the main countries in this trial, is significantly lower than it is in the US. And so even though in the US we have a 39% adenoma detection rate, they don't have that in Sweden. They shouldn't have that in Sweden because that's not the rate of adenomas in Sweden. Since in the US, adenoma detection rate has been used as a quality metric, the rate of adenoma detection has gone up because people are penalized for not detecting enough adenomas. So it's not a real detection rate anymore. Now it's a gamed metric. Of course, in Norway and Poland, the detection rate was 30%, which is well above the current threshold for good quality because that is the rate of adenomas in those countries. They don't have the lower rate that Sweden does. The study author actually says that's why he doesn't think the argument is valid. At this point, I'm forced to discuss the unfortunate reality that colonoscopies pay a lot of money. GI is a very lucrative specialty. And the reason it's very lucrative is because every single person over age 50 or over age 45 now is supposed to get a colonoscopy screening. It is a procedure, and procedures are reimbursed by insurance and Medicare at a much higher rate than thoughtful medicine. Procedural medicine is the standard of payment for a variety of reasons in our country. And so all the articles by GI doctors coming out, like this one by gastroenterologist Robert Braselier, University of Texas MD Anderson Cancer Center, who promote the per protocol analysis of only the 42% who participated, have at best a complete lack of scientific literacy. And while I could understand a layperson saying, well, why don't we only look at the ones who got the colonoscopy? Very understandable for a layperson to say that. For a GI specialist to say something like that is either indicative of a complete lack of understanding of science or a deliberate attempt to defend a lucrative procedure. I am having a hard time seeing it in any other way. If there had been a pre-existing body of knowledge, a pre-existing set of randomized studies that had a different result, and this were the first trial to show something like this, it would be reasonable to question. But this is the first trial. This is the first bit of evidence. Everything else was speculation. We suspected that doing colonoscopies and catching these polyps would reduce the rate of colon cancer death and would reduce mortality. Just like we thought mammograms would reduce mortality, just like we thought PSAs would reduce mortality. But they don't, and they don't, and they don't. Quoting a relative risk reduction statistic of 31 and 50% on a per protocol analysis, instead of a 0.38 absolute risk reduction or a 0.15% absolute risk reduction in absolute risk of death, even in the per protocol analysis, which is probably due to other health behaviors, because you've destroyed the randomization by choosing to look at the per protocol analysis, is frankly just academic fraud. And I can't help but think that some of them know that. And if they don't, they damn well should. Thank you.